And today we have Dr. John Roshan and Dr. Raja Selvaraj as the moderators of the session. And just as Dheeraj, please put everybody on mute. He muted me too. So kindly, both the moderators, please unmute yourself. And over to you both, Dr. Raja and Dr. John.
Good evening and welcome everyone. We're all looking forward to today's talk from Dr. Krishna Kumar, who's a very good friend of mine. And before I start, I also want to just briefly mention that this whole academic program weekly that we are having has been an excellent initiative from IHRS, and I'd like to congratulate the people involved in this, especially Dr. Vanita Arora. So to introduce Dr. Krishna Kumar, he did his medical training in India in Trivandrum. His MBBS and MD were from Trivandrum Medical College, and then he did his cardiology training from Sri Chitra. And after briefly working as a faculty there, he came over to Toronto to do the EP fellowship, where we worked together as fellows for a couple of years. And he has continued to work there as a staff in electrophysiology. And he has been running the adult congenital heart disease program there. And the way it is set up there, they have referrals of adult patients with congenital heart disease from various places, and they also have the hospital for sick kids right opposite. So they have a really good volume of these cases. He has extensive experience with these patients. We've had the pleasure, John and me, hosting him here and having some workshops. So it has always been a pleasure interacting with him. So I'm very happy that we have him here to talk to us today. And without much further ado, I'll ask him to start his talk.
Thank you, Raja. Thank you for the nice words. And I want to thank all the organizers for inviting me for this talk. It's my honor and privilege to present here. So I'll talk about ablation of arrhythmias and adult congenital heart disease. So my slides are not moving. Okay. So this is where Raja, John, and I have trained. And that's where I work now. So I will talk about only atrial arrhythmias today in the interest of time. And there was a great session by Dr. Maulish a few weeks back. So I'll mainly concentrate on cases instead of just talking about just giving a didactic lecture. I'll focus on mustards and Fontans because they are the most difficult ablations to do. So are radiofrequency ablations useful in atrial arrhythmias in adult congenital heart disease? This is data from our center, which we presented last year at Heart Rhythm. We found that if we successfully ablate atrial arrhythmias, success means we define success as termination of tachycardia with radiofrequency ablation. Successful ablation reduces the risk of a future cardioversion by 40%. This was a group of 157 patients. We all know that patients with adult congenital heart disease who have had an operation have a high prevalence of atrial flutter, and they're usually macro-reentrant. Atrial fibrillation is not very common, though we see it in older patients, sometimes in left-sided cardiac lesions in end-stage heart disease. And time is one of the very significant risk factors, the time after surgery. You know, one of the general dictums is that if you have two atria and two ventricles, you should always check the cavo-tricuspid isthmus, because it's probably the commonest arrhythmia overall in patients who have got two atria and two ventricles. And this local activation time map is very familiar to this audience of electrophysiologists. So there are 2 or 3 important things to remember while preparing for these cases. We should always have access to the operative note. It's very important to read the operative note and understand what the surgeon actually did. And even more important is to look at the imaging and to understand exactly how the atria and ventricles and the great arteries are related. And also to confirm situs. And finally, because we deal mainly with adult patients, many of them have had multiple surgeries in the past. Access may be a problem. So peripheral Dopplers are not very helpful. If you have a question, we do a CT angiogram to establish continuity of the femoral veins through the iliac veins into the inferior vena cava. So, you might be surprised on table. You might see that the IVC is interrupted and continues as the azygos into the superior vena cava. So in patients like this, we typically use a deflectable sheath, like an ageless sheath, and we get access from the neck. The problem with access from the neck is that it's hard to manipulate catheters, and for the same person to do both the femoral and the neck vein. So now we take access from the right axillary vein, and we go through the leg with a deflectable ageless sheath and go down. This is a patient who had congenital heart disease and 2 different arrhythmias, and we could successfully ablate focal atrial tachycardia and just a aortic dependent atrial flutter. Sometimes you see this in complex anatomies too. This is a patient with an RA to PF Fontan with IVC interruption. So again, we use the same strategy. We use a deflectable sheath, and sometimes we are lucky and we're able to cannulate the coronary sinus from within the right atrium. So we take a neckline or a right axillary line and cannulate the coronary sinus, and that gives us a stable reference catheter. I'll start with atrial flutter in post-atrial switch patients. So most of, because Dr. Mustard was across the street here, most of the patients are post-Mustard, though sometimes we see patients who have had a sending operation too. So atrial tachycardias in this population may be life-threatening, and as Dr. Shah alluded to, because of very slick AV nodal conduction, they may have very fast ventricular rates, and they may collapse in the emergency or at home. Both atrial flutter and atrial fibrillation are predictors of sudden cardiac death in this population, and very often they indicate some form of hemodynamic deterioration in these patients. So, just to show the anatomy in these patients, so typically they're born with the right atrium going to the right ventricle, which goes to the aorta. So there are 2 parallel circulations, and the patients are born cyanotic. Well, post-atrial switch, the right atrium is now connected to the mitral valve in the left ventricle, and the left atrium and part of the right atrium are sort of sutured together. A baffle is created. This is connected through the tricuspid valve to the right ventricle. So depending on the series, at least 25% of these patients have tricuspid dependent atrial flutter. Maybe slightly more in some other series, but they may have scar-related flutter, rarely AVNRT, and rarely focal atrial tachycardia, and then what is called NAFAT or non-automatic focal atrial tachycardia, which is actually micro-reentry. And Joel Kirsch, with whom John Jacob also trained, showed intervals between successful, showed that the intervals between successful cardioversions become shorter with time. So it's important to intervene early in these patients. The conventional approach to doing these patients is going retrograde. I mean, you can reach the systemic venous baffle or the right atrium easily through the leg. But to access a pulmonary venous atrium, typically you go retrograde aortic. You go through the aorta backward. But the problem is stability of catheters. That's possible to do. And this is how we used to do it here too. We go retrograde through the aorta, through the aortic valve into the systemic ventricle, and then through the tricuspid valve back into the pulmonary venous atrium. So the catheter has to make multiple turns, and sometimes it's difficult to get catheter stability. This catheter, the inferior catheter, is a quadripolar catheter which is in the systemic venous baffle. So this is an RAO view. In LAO, this catheter will be more medial because the pulmonary venous atrium encompasses, the systemic venous atrium is in the middle of the pulmonary venous atrium. So the pulmonary venous atrium will be lateral in LAO to the systemic venous atrium. All our patients now, we use baffle puncture, we use intracardiac echo. We used to use transesophageal echo, but we go with intracardiac echo now with a regular needle, and we always use deflectable sheath. So this is the baffle puncture, and like Dr. Shah said earlier, the puncture is anterior. We go anterior in the lateral view. So just to show the anatomy. Sorry, I'm just yeah. So this is an injection into the pulmonary venous atrium, and the traxid valve is filling the subaortic ventricle and the aorta. This is an injection into the systemic venous atrium, and that fills the mitral valve, the subpulmonic ventricle, and the superior baffle. The left atrial appendage is usually a part of the systemic venous baffle. The location of the coronary sinus is variable. In our patients, you know, because of the surgeon's preference, the coronary sinus was often left in the systemic venous atrium, so we can often cannulate it in our patients here. So this is an activation map of the pulmonary venous baffle with the tricuspid valve and the systemic venous baffle seen together. And this is typical tricuspid isthmus dependent atrial flutter. And you can see that the isthmus is shared between both baffles. So here's the systemic venous atrium, the inferior baffle, and the mitral valve. And that is the tricuspid valve. And you can see the activation map. You have counterclockwise atrial flutter going through the tricuspid isthmus. And the part between, this little part from the IVC to the pulmonary venous atrium, which is on the systemic venous side. So in this particular patient, there are also fragmented signals on the posterior part of the pulmonary venous atrium. Very signals which, suggest that there is a macro reentry or micro reentry here. And here was the activation map, which did not make a lot of sense. The broad band of activation with a lot of fragmented signals, and the signals annotated in different ways depending on whether it's systolic or diastolic. But overall, the activation map does not make a lot of sense, so we entrained. And we found that the post-pacing interval was very long, indicating that this was a bystander. So we ablated in the isthmus, and this is autopsy section borrowed from a different publication, which shows the tricuspid isthmus, and you can see that the anterior part of the tricuspid isthmus is on the other side of the baffle. It is on the pulmonary venous atrial side, close to the tricuspid valve, and the posterior part is in the systemic venous side. Ablations are done like we typically do. We go to, just like we do any tricuspid isthmus dependent atrial flutter. We just go to the LAO view and tilt up, and very similar ablation with the ablation line drawn straight down. But remember that the systemic venous baffle is more medial to this in LAO, and you'll have to extend your ablation line backward from there. So this patient's flutter was terminated at the tricuspid valve end with radiofrequency ablation. Following ablation, you have to demonstrate block, and again, this slide was shown earlier. And this maneuver was described by Balaji Seshadri from Portland. So the principle is the same, like differential pacing. So again, you look at the LAO view, you see the tricuspid valve and the systemic venous baffle. You're ablating here. So clearly you have catheters on both sides. So your ablation catheter or your penteray, you can keep lateral to your ablation line. Medial to the ablation line, you can keep one catheter in the inferior baffle and one in the superior baffle. So if there's no block, if you pace from lateral, the lower part of the systemic venous baffle should be activated first, and then the upper part. If there's block, then the upper part gets activated first. And same is the reverse. When you pace from the inferior part of the systemic venous baffle, conduction should go rapidly across to the pulmonary venous atrium if there's no block. If it does not, then there is no block. So this is a patient with no access from the legs, but luckily had a baffle leak. And you can see us going through the systemic venous baffle, probing for the leak, and then injecting contrast. You can see the pulmonary venous atrium, the tricuspid valve, and the subaortic ventricle, and the aorta filling. And I know that most of the audience is very familiar with interventions, and we just put a wire through that and then pass the deflectable sheet down. And we found diastolic signals in P wave diastole, and they were right at the inferior part of the pulmonary venous atrium. There's some annotation, the interpolation. This was pre-confidence before we got multielectrode mapping and automatic mapping. So there's some interpolation here, but the diastolic signals were in the middle, and we ablated and terminated tachycardia. this is another patient with a mustard, one of our older patients who presented with palpitation, but this is what his ECG looked like. And many of these patients with post-atrial switch will have ECGs like this, where you can hardly see any atrial activity. And it is the explanation is that if these patients, in these patients, the atrial septum is removed. They have atrial septectomy so that the baffle can be created. And this takes off a significant amount of the electromotive force required to generate a P wave. So you may not see any P waves at all. Luckily, this patient, as you can see, has got a device and clearly we could see atrial flutter. And this atrial anti-tachycardia pacing, which was not working. So this patient had cavo-tracheostomy dependent atrial flutter, which we ablated, and then when we re-induced, we found a second flutter, and the map looked like this. This again before confidence and automatic mapping, and this is late in the day. A quick map showed that centrifugal activation, and we saw these signals on the distal part of the ablation catheter. And I'm just blowing that up for you. So you have V pacing and then you have flutter. And if you look at the distal electrode of the ablation catheter and compare it to the proximal, you could think that this is just focal atrial tachycardia with the 2-to-1 conduction. But you see that there is alternance both in...
hello?
Hello?
Ah.
Hello? Yeah. Yes. Is there a question?
Go ahead, sir. Must have been an open mic.
Oh, sorry, sir. Okay. So you can see on the distal electrode that there is alternance, right? So there's alternance both in ventricular EGM morphology and also in cycle length, right? So what could this be due to? So these are the two possible explanations. So actually, John Jacob was involved in this case in 2013. Yeah. So the distal part of the ablation catheter shows is possibly right on top of the micro-reentrant circuit, and it is able to capture both limbs, activation in both directions. So the proximal part is just off, and that's why you have got this appearance of 2-to-1 conduction. It's also possible that you're right on top of a line of block, and you're getting 2 waves of activation, which are in different directions, and therefore you're getting this alternance in morphology. So we entrained, and we obtained a very good post-pacing interval to cardiac cycle length match. And the propagation map showed centrifugal activation. So this is what is termed by some people as NAFAT, of non-automatic focal atrial tachycardia, radiofrequency ablation terminated tachycardia. So it's not, the macro reentry is very, very common in mustards and very common. It's cavo-tracheostomy dependent. You could also have micro reentry or some of these focal tachycardias too. Rarely you can see AVNRT, and it depends on the surgeon as to what the relationship of the coronary sinus and the AV node will be. Very often the AV node is on the pulmonary venous atrium, so you'll have to do a baffle puncture or go retrograde. And we usually do AVNRT ablations, like all of us do, based on the location of the coronary sinus ostium. But the coronary sinus ostium might be on the systemic side, depending on what the series is like. Like in our hospital, usually the coronary sinus is in the systemic venous atrium. AVNRT is not very common in this population, and it is believed that it's because of manipulation and dissection of the septum that you take off the inputs into the AV node, and very often the slow pathway itself might be completely disrupted in these patients. So this patient actually had recurrent palpitation and syncope, and she had a loop recorder which showed this rapid narrow chorus tachycardia. And you can see a short VA tachycardia, AV node echo, ventricular pacing dissociated the atrium, atrial tachycardia. The atrial rate continued irrespective of capturing the ventricles, so we ruled out a pathway. Initiated tachycardia with an AH jump, and we did a baffle puncture, and these are images created using Carto sound or ICE, which used very commonly. And I've used cryo. So there's the cryo catheter and the His bundle, and we're ablating lower down, and the patient's tachycardia became non-inducible. Sometimes we have to do baffle punctures in some other anatomies too. So this is a patient with congenitally corrected transposition, where the right atrium leads to the left ventricle, which leads to the pulmonary artery, and following a double switch operation, the right atrium is now both the atria and the ventricle are switched. So the right atrium now goes to the right ventricle, which then goes to the pulmonary artery. So this is one of our patients who had a recurrent atrial flutter, and we performed a baffle puncture, and this is a typical setup with quadripolar catheter in the subpulmonic ventricle. We map with a pentarray catheter, which is in the pulmonary venous atrium. The ablation catheter is in systemic venous atrium. We found this large macro re-entry circuit. I think some of the lines are a little bit off, but basically it's macro re-entry with next to a scar in the pulmonary venous atrium in this patient post double switch. Radio frequency ablation terminated tachycardia by transecting this isthmus. And rarely we have patients who have a combination of atrial switch and the Rastelli operation. These are patients who have congenitally corrected transposition with VSD and pulmonary stenosis. And one of the other options is this operation called the Ilbavi operation, where the anatomy is similar, but they have a Glenn in addition. So this is a patient who is post Ilbavi operation for congenitally corrected transposition of VSD with PS. You can see a clear figure of 8 circuit here on the map. Just ripple again showing activation in the figure of 8 pattern. Radio frequency ablation terminated tachycardia here. I'll now move on to Fontan ablations. So I think a similar or the same picture was shown earlier in Dr. Shah's talk. So you have basically 3 iterations of Fontan operations. So you have the RA to PF Fontan, and then you have the intracardiac lateral tunnel, where you have a Glenn and a tunnel within the right atrium which connects to the right pulmonary artery. And then you have the extracardiac Fontans, where you have SVC to IVC tunnel, which is just outside the heart. So atrial pulmonary Fontans are very, very prone to atrial arrhythmias. Up to 60% of patients will have atrial arrhythmias. And most of them are scar-related or intra-atrial reentrant tachycardia, though sometimes you may see these focal atrial tachycardias or NAFAT. The true instance of atrial fibrillation is unknown in these patients. Many arrhythmias labeled as atrial fibrillation on surface ECG may actually be macro reentry on EP study. So many patients are converted from an RA to PF Fontan to an extracardiac Fontan just for the indication of arrhythmia. And we looked at our patients here. These are all patients who have had an extracardiac Fontan. And we found that patients who undergo de novo surgery do very well. They don't have a lot of arrhythmias. But patients who undergo an extracardiac Fontan conversion, that is conversion from a RA to PF Fontan to a total cavopulmonary connection, still have a significant burden of arrhythmias despite undergoing a biatrial MACE procedure at the time of Fontan conversion. So we believe that catheter ablation should be considered always in RA to PA and intracardiac lateral tunnel Fontans before they are referred for revision to an extracardiac Fontan. There are some challenges to radiofrequency ablation in these patients. Sometimes patients have multiple reentrant circuits. It's impossible to map as we all know, if the patient has multiple arrhythmias with no stable arrhythmia with changing cycle length. Rarely they transform to atrial fibrillation. Sometimes you have non-sustained, non-inducible tachycardia, and substrate mapping is not very effective in the atrium, unlike the ventricle, where, especially in ischemic cardiomyopathy, where you can effectively substrate map and ablate. The chambers are extremely dilated, and we have to use a deflectable sheath and contact force. They have large areas of scar and complex boundaries, and very often the activation map and the propagation map will suggest more than one critical isthmus. And as has been discussed earlier in the previous talk, right atrial thickness is can be as thick. The right atrium can be as thick as 20 millimeter, making it very difficult to create transmural lesions. The surgical data from Barbara Thiel. This is a typical RA to PF Fontan. This patient was referred to as atrial fibrillation, and for this audience, obviously, it's very clear that there is grouped beating. So clearly, we're thinking about atrial flutter or atrial tachycardia. This patient actually had termination of tachycardia on the ward on intravenous amiodarone. The patient had been given a lot of beta blockers too from elsewhere, had severe bradycardia, hypotension, and we cannot put a temporary wire in, and actually developed had to be finally intubated, had ischemic hepatitis, multi-organ failure, so finally got extubated. And the question was whether we implant a pacemaker straight away and treat medically or radiofrequency ablation. This is one of our old cases, actually. And we found on radiofrequency ablation that she had the scar-related macro-reentrant flutter. You can see all the colors of the rainbow around a scar with the propagation map clearly suggesting macro-reentry. And clear diastolic signals too. Termination with radiofrequency ablation. There's one type of Fontan operation called the Bjork modification, where actually the right atrium is connected to the right ventricular outflow tract. And we have found in these patients that very often they have cavo-tricuspid dependent flutter. And despite using electroanatomic mapping for all these patients, we always have a duodecapolar catheter. And if you're lucky enough to cannulate the coronary signs like we could in this patient, you can see from the duodecapolar catheter itself that this patient has typical isthmus-dependent atrial flutter. So we ablated and terminated tachycardia here. So, so in any patient with a Bjork Fontan, it's important to remember that it might be CTF flutter, and very often it's possible that we neglect to place our Pentaray catheter on the isthmus and the inferior part of the right atrium, and the map may make no sense at all if you map the rest of the atrium. Very important to cover the isthmus, especially in this type of Fontan. Rarely, like Dr. Shah alluded to, you might have to go, there's a little part of the right atrium on the left side, and either you have to use stereotaxis or a puncture to just get it across and ablate in that region. These are intracardiac lateral Fontans. And this is a unique type of intracardiac lateral Fontan where the tunnel, instead of being opposed to one wall, was like a pillar in the middle of a room. And we could puncture, and like many of our patients require balloon dilatation and cutting balloon, and sometimes multiple dilatations, and it's taken us about 1.5 to 2 hours sometimes to get across. And I always get the help of an interventional cardiologist who does this every day to help us. In this particular patient, there's one patient where stereotaxis could be very helpful because we could because the tunnel was in the middle of the right atrium. We could puncture and get proper access only on one side. And in fact, at the end of this procedure, the rotating mechanism on the edgeless sheath got broken because we're turning it so much. But otherwise, our regular lateral Fontans are on one side of the atrium. And here you can see a macro reentrant circuit. But if you look at the colors look different. And you can see that we have placed our ablation lines right in the middle of green. And obviously, as all of us know, this depends on how we set the window of interest. And here the window of interest was set with the P wave at one end of the P wave was at one end of the window, so that diastole will be green in color. So it's very important to know how we set up the window. Typically, we keep the P wave in the middle, just to take off one variable so that we know exactly where the possible isthmus is. But this patient was done in a different manner. Again, some of the intracardiac lateral tunnels may be as bigger than a regular right atrium, and you cannot do this procedure without a deflectable sheath and contact force. This is just an example of the amount of scar and multiple areas of slow conduction. It's hard to know exactly where to ablate because sometimes the colors may not make a lot of sense despite annotating and re-annotating, and then you have to go to multielectrode mapping has made a huge difference, automatic mapping, and we are able to, like all of you do too, using a Pentaray and using the confidence algorithm, we can map rapidly. It's really helped us in these patients. And, we had very good success rates when we looked at a small number of our patients over a period of time with this automatic annotation algorithm. This is the patient I just showed earlier, where you can clearly see The propagation map shows macro reentry. We entrained here, and we got concealed entrainment, as you can see, with comparable intervals between post-pacing interval and tachycardia cycle length, and ablation slowed and terminated tachycardia. So we found that in many of these patients with intracardiac lateral tunnel, we could successfully ablate tachycardia within the tunnel itself. So we looked at all the patients where this happened, and we found that in a significant number we could do this, though not in all patients. So this is change our approach to intracardiac lateral tunnel Fontans. We always, before we do the baffle puncture, we first map the tunnel and make sure that the tachycardic circuit is not in the tunnel. And if it's not there, then obviously we'll puncture and try to ablate. Here is a pictogram of an extracardiac Fontan, where you have the tunnel just outside the right atrium. Here we're puncturing, trying to get across, dilating, and ultimately, getting the catheter into the atrium. This patient had a very large left SVC to coronary sinus, and you can see that it looks almost, the propagation map appears to show centrifugal activation, like non-automatic focal atrial tachycardia. Yeah. I'll show you our pentarray signals from here. This is the pentarray. I don't know if Sachin Nair is there in the audience. He was with us at this time and has created this beautiful picture. So this is the pentarray right at the inferior part of the atrium, near the ostium of the left SVC to coronary sinus, and you can see that the entire cycle length is on the pentarray. And you can see clear diastolic signals there, in P-wave diastole. And he's mapped out the systolic part and the diastolic part on the pentarray. A lot of effort and a lot of work. We could terminate with radiofrequency ablation in this region. Rarely, this is a patient with intracardiac lateral tunnel Fontan who had recurrent tachycardia. And when we see a narrow QRS tachycardia in a patient with intracardiac lateral tunnel, straight away we think of atrial flutter. But if you look at this ECG, you can see VA dissociation. There are more V's than P's, and it narrows our differential diagnosis to either AVNRT or junctional tachycardia, or a nodoventricular or nodovascular tachycardia. And we found that this patient actually had junctional tachycardia. You can clearly see VA dissociation. And this is cartosound created anatomy. Because it's an intracardiac lateral tunnel, we had to puncture. We mapped the earliest activation in the ventricle and also the his bundle, and luckily could get away with radiofrequency ablation and terminated the patient's tachycardia. I don't know how much time we have. Let me have a look. Yeah, so I think I have time. So briefly about Eisenmenger. So these patients are high risk for any intervention and sudden death and anesthesia. So whenever we do these patients, we always check the anatomy and see if the AV node is displaced, because they may need epicardial pacing if there's AV block, especially patients with large VSD. This is a patient with VSD Eisenmenger with, as you can see, clear AV and RT with an R prime in lead V1. And when these patients have non-inducible tachycardia, it becomes a little challenging. So if you give isopranoline, it can cause peripheral vasodilatation and increase the right to left shunt, and the anesthetist is very reluctant to permit us to give isopranoline. So what we have done in the handful of patients that we have done is we give a vasoconstrictor like phenylephrine first, and then combine that with isopranoline, and we have been able to induce tachycardia successfully without causing any decompensation in these patients. It's just the same patient with the VSD Eisenmenger with the his bundle mapped and successful radiofrequency ablation in the slow pathway region. As you can see, many of our patients we have entrained, but sometimes the problem with entrainment, as was alluded to in the previous talk, is that you can transform one tachycardia to the other. You might even terminate tachycardia and then never induce it again. So we use entrainment whenever the activation map and the propagation map does not make sense, or we see two critical ismi, or there is a set of fragmented signals which look like bystanders. And one of the challenges, and this patient was done with John Jacob recently, and one of the challenges is that the post-pacing interval could be shorter than the tachycardia cycle length. And as we know, it's well described that this is because you're pacing at high outputs, and you have a big virtual electrode which is capturing the circuit more distally, so that you have a shorter post-pacing interval. And in this region where we had the shorter post-pacing interval, there is classic diastolic signals with the propagation, local activation type making a lot of sense, and radio frequency ablation here terminated tachycardia. Very often we see the reverse too. Especially in tricuspid dependent atrial flutters, when we try to entrain, we get a long post-pacing interval. However, the atrial activation time on the coronary sinus, the duodecapolar catheters, or even the Penta will be exactly identical. So in these patients, we always do activation map with the Penta, and almost always we find that the decrement was that the circuit is exactly there, though the post-pacing interval was long. Very well described by Gregory Michaud in patients without congenital heart disease. So, you may have long post-pacing interval minus tachycardia cycle length, but still be in the circuit. So we ablate there. So that's the one thing I want to talk about entrainment. And for extremely difficult anatomies, one of our anesthesia colleagues is a 3D printer, and this is a patient with visceral heterotraxy with interrupted IVC, and with the help of our colleague, we are able to create a 3D model, and we look at it and plan the procedure. So this patient actually was waiting for the procedure, but now has transformed into flutter, from flutter to fibrillation. So she did not actually get ablated ultimately. So I think I've finished in time. So to summarize, treatment options and interventions in adult congenital heart disease must be critically assessed to guide tailored therapy. As you can see, the challenges are mainly due to anatomy. It's good to have a preoperative CT scan, and you can merge with using CartoMerge. You can merge that with your map. And when possible, you can use a 3D model if it's available. And catheter ablation definitely reduces subsequent cardioversions, and always preferred over arrhythmia surgery. And specifically in intracardiac lateral tunnel Fontans, it may be possible to get away without a baffle puncture and just map the lateral tunnel alone. Thank you.
Thank you, Krishna, for the lovely talk. And the session is now open for questions. I just had one doubt, Krishna, when you do these punctures, if you've got a extracardiac Fontan, so sometimes you need to enter from
Yes.
the Fontan circuit, the extracardiac thing, into the systemic venous atrium, and then from there into the pulmonary venous atrium. So do you do both punctures at one shot, or you do it step by step?
So almost, so when the extracardiac Fontan and also for intracardiac lateral tunnel Fontans, how the operation is done, that most of these patients have atrial septectomy. So they have a common atrium. So we just need to do one puncture. So if you think about the circulation, they have a common atrium. So it's just one puncture here.
Dr. Sujit Majumdar wanted to know whether DC cardioversion should be the first line in intra-atrial reentrant tachycardias in Fontan, or whether we should go ahead with ablation.
So, it depends on lap time, and it's specific to the institution. Here, in our patients here, every patient we cardiovert right away because we don't have enough lap time to do these patients urgently. Because remember, I showed you the electrograms of the patient who decompensated while waiting in flutter. They don't do very well if they're left in flutter, especially at fast ventricular rates for a long time. And there are some precautions to take, obviously, for cardioversion. You should never cardiovert in the casualty or the emergency room. You should cardiovert in the CCU, because if you have bradycardia, you'll be in trouble. should have isoprenylene ready or atropine or glycopyrrolate ready. You should be able to transcutaneously pace. But we always cardiovert, and before cardioversion, we stop all AV nodal blocking agents at least for 12 hours. So if you can, and we usually do a transesophageal echo also in these patients, even though they are appropriately anticoagulated. Some patients will be very far or actually on newer oral anticoagulants, and there's not a lot of data on these patients. So all these patients undergo transesophageal echo. So in this hospital, we always cardiovert, but if you have lab time and you can take them directly, great, you could just obtain radiofrequency ablation.
Do you get imaging done before your procedures routinely, or do you rely more on the maps that you create?
So earlier we are doing, many of these patients have devices, so you can't do an MRI. But those patients without devices have routine MRIs every 1 to 2 years. I think Dr. Shah had the same question. She said, all adult congenital cardiac centers, the patients who come have routine MRIs every 2 or 3 years. So we just look at a previous MRI. I try not to do a CT in these patients because of radiation. So if the creatinine is normal, I'll do an angiogram on table, and then we use cartosound to delineate anatomy. So that's what we're doing now. The MRI, to merge the MRI into Carto, we don't have the software. But in the UK, we have colleagues in the UK who are able to merge MRI to Carto. We can't do that here in this hospital.
So Krishna, I just had one question. How do you think
Raja, before you start, your questions are always going to be tough. Okay, I'm going to take a deep breath.
I was going to say, what do you think how do you think the spectrum of cases that you will handle will change with time, like in the next 10 or 20 years? Because I think mustards you're going to see less and less, right? As the people who had mustards are going to go off. And similarly, I think most Fontans are going to be extracardiac. Probably you'll have less complex arrhythmias. So what other arrhythmias you think will take center stage and become more challenging and will be the main things that you treat?
Sorry.
I think someone's audio is on. Let me just check it out.
Okay.
Yeah, just a second.
Yeah, sure.
I think they put it on mute. Please go ahead.
Yeah. So, Raja, I mean, that's a great question. That's what we see. Some of our older patients, some of the older survivors have started to develop atrial fibrillation, though that's not common. Tetralogy of fallow VTs used to be very common earlier. Especially when we are training, it's much more common. But now we don't see that many because of, it was already discussed by Dr. Shah last time. It's because of the transatrial approach and sometimes the transpulmonary approach that we don't see a lot of tetralogy of fallow VTs. And there are the only patients who undergo atrial switch are those who do not qualify for an arterial switch. So we'll have less and less of those arrhythmias. But I think we'll continue to have scar-related atrial flutters, that they don't go away. Any patient where that's a next to cavotractable isthmus dependent atrial flutter, the best spot to go to ablate in sinus rhythm is to find where the surgeon cannulated the atrium. And if you see fragmented signals there in the atrium, though it's not been validated, but suppose you can't induce tachycardia and the isthmus is blocked. If you want to ablate, if you map the atrium and you find the putative site for the cannulation, which is usually posterolateral in the atrium, that's where most of the tachycardias begin. And all patients will require RA cannulation unless somebody does SVC, IVC cannulation alone. So those tachycardias will remain. But that's what we're saying. Yeah. Also, though there's some controversy about this, overall, what we see here is that though extracardiac Fontan patients also have atrial arrhythmias, they're much less than patients with RA2PA Fontans. But the critique to that comment is data from Portland, where they said that if you follow the extracardiac Fontan patients long enough, they may have the same number of arrhythmias. But generally, what we see is that so far, they have less arrhythmias.
So there is one more question in the chat, actually. So Suchit again is asking, in mustard, when ablating CTI, That you have to, part of it is on both sides of the baffle. So I guess the question is it always like that? And how do you approach that? How do you try to create a continuous line of block by approaching it from both sides? I think some of it is covered during the talk, but probably just wants to be.
Yeah, I'm sorry. I apologize if I was going fast, but I was worried about time. I didn't want to waste anybody's time too. And we all have a usual pace at which we talk. And unfortunately, I think I speak a little fast. But basically, it depends on the center and the surgeon. So in this hospital, if a patient has a CTI-dependent flutter following a mustard, we will not be able to terminate tachycardia by ablating only in the systemic venous atrium. So it depends how the baffle is sutured. And there's a beautiful picture which Dr. Shah showed last time. I didn't want to show this duplicate images. So it depends on where the baffle is stitched by the surgeon. If the surgeon stitches the baffle very close to the tricuspid valve, the most of the CTI will be in the systemic venous atrium. And vice versa. If he stitches the baffle very posteriorly, most of it will be in the pulmonary atrium. In this hospital, most of the CTI is in the pulmonary atrium. So we absolutely have to do a baffle puncture or go retrograde. Or in the center, we don't have stereotaxis. It's there only in the neighboring city. They could do stereotaxis. So we have to, how the procedure is done is we mark the tricuspid valve. How we do it now is we do the puncture. We take angiograms of the systemic venous atrium and the pulmonary venous atrium. Then using cartosound, or eyes, I mark the tricuspid valve carefully. So I know where the tricuspid valve is. And then we draw an ablation line from the inferior part of the tricuspid valve back to the systemic venous baffle. So remember, the systemic venous baffle is medial to the pulmonary venous atrium. So you have to draw the ablation line quite medially. But the worry always is that you may take off some of the inputs to the AV node and produce AV block. We have never had that problem, but there's an old series where 50% of patients had AV block following a CTI line. So we have not had that problem, luckily, but we draw this line very medially on the pulmonary venous atrium, then go to the systemic venous atrium and continue.
Since you use both eyes and TE, so how do you think what is the feasibility of using TE alone in places where either we don't have access to eyes or we don't want to put a large venous sheath for putting them in complex
eyes? Yeah, eyes. If you use eyes, of course, it adds cost. Even here, eyes and cartosound certainly adds cost. But the practical aspect of the TE is that you need an echocardiographer who's familiar with congenital heart disease, and we should be speaking the same technical language. What has happened when initially the baffle punctures are done using TE? So the echocardiographer will say, I'm going to show you the systemic venous atrium, but he means something else. Okay. He'll say, the usual term they use is subaortic atrium or subpulmonic atrium, or, and you're not sure whether we are talking the same language. So with eyes, you're in control, you know what you're using. But of course it adds cost, and it's a huge sheet that goes on the left side, and that's the difference. But if you have a good echocardiographer and you understand TE well, and if you can discuss before, I think that's how we used to do it initially. Also, the other big difference with TE, we have to do it under general anesthesia, otherwise the patient will move during carto. With eyes, we don't need general anesthesia, just conscious sedation, we can do the puncture. The other practical aspect to the puncture too is that we have to go to left lateral. Unlike most of our procedures we do in RAO and LAO, for the puncture here, because we have to be sure we are going anteriorly, we have to go left lateral. But that means both humeri will be in the way. So radiologically, you won't be able to see it. So you have to ask the patient to keep both hands on the forehead. We should tie it down or in the back of his head. But if you do it for a long time, you could produce brachial plexus injury. So we do this just before the puncture and take the arms down right away.
John, you have to unmute yourself, please.
Yeah, I think we don't have any questions as of now. So Do you think we should close the session, Dr. Vanita?
It's up to you, Dr. Raja and Dr. John, and KK, of course.
Okay, first.
Yeah, John, I think if you don't have anything else to add, I think we can stop now.
Yeah, the only thing I would like to add is that a lot of these patients are sicker than they appear.
Yes.
These patients who have congenital heart disease and come with arrhythmias to you, they may often come with an ejection fraction of around 47, 48 or 45%. And they usually come walking in and they look apparently well. But I think we should be very cognizant of the fact that they're actually sicker than they appear. And it should be something that we are wary of, like Krishna just mentioned, cardioversion should always be done with all the precautions in place and not like a casual cardioversion that you do for a relatively young person who comes with atrial fibrillation. And same way, I think even when we do ablation procedures for these patients, we need to be cognizant of the fact that they're sicker than what they normally are. And I think it's always good to have an anesthetist around when we do these procedures. Because often we are engrossed with the ablation procedure that we don't have time to monitor the other parameters.
Yeah.
Yeah,
Sorry.
please.
No, that's a very good point. Actually, we switched from all the mustards, we are going retrograde aortic. The reason for switching to a baffle puncture is because of one patient. I was mapping a flutter, but we are going retrograde. So we have to go aorta, ventricle to atrium. And the catheter is going, the shaft of the catheter is going back and forth, and we induce VT in the patient. But, like I think Dr. Shah alluded to the same thing. If you have flutter for a long time, the patient may have lactic acidosis, metabolic acidosis, despite a good anesthetist, and tissue hypoxemia. And I pulled the catheter out, but I could not break the VT. I cardioverted the patient 3 times, but I could not stop the VT. I thought we'll lose the patient, but luckily, finally, he converted. So after that, I switched to the baffle puncture technique just because of that one patient. And he came walking in. And, we underestimate these patients. If a patient has a stroke, obviously he'll walk. We're fortunate to be cardiologists. The patient may have a huge anterior aneurysm, but he'll walk, he'll look fine. But the CVA, he looks paralyzed and he'll never be happy with a neurologist. Similarly, these patients may have a bad heart, but they'll just walk into your OP and, you should not underestimate how sick they are.
Yeah, so we had a very similar unfortunate experience as well. We had a patient who had AVNRT post-mustard, recurrent episodes of AVNRT, very symptomatic from it. And we did all the necessary planning, did all the imaging before the procedure, created a beautiful map with the NAVIX, got the entire anatomy straightened out, figured out where the slow pathway was. But the patient was in AVNRT all through, and we didn't realize that this is AVNRT in a patient post-mustard as compared to regular AVNRT that we see. So at the end of it, we identified the slow pathway, got rid of the AVNRT, but the patient after that had a ventricular standstill for a short while, CPR, and then in another 2 days, patient actually passed away. So in retrospect, I think keeping the patient in the arrhythmia for such a long time, like Krishna just mentioned, going into acidosis and all that actually caused the detriment. We have another question from Dr. Santoshi. In terms of patients who need surgical intervention, do you think you have to undergo EP testing for all patients, especially the top patients?
So, it's not very clear from the guidelines, but we individualize a decision. So what we go is, we look at a number of things, and there's a score that's published by Paul Carey from Montreal. We classify patients into low risk, intermediate, and high risk. And the features, like we all know, we look at the QRS duration, presence of non-sustained ventricular tachycardia, previous ventriculotomy, previous BT shunt. The scoring system actually uses left ventricular end-diastolic pressure more than or equal to 12. But some of these patients may not be cath, so we look for LV dysfunction. So if the patient has any of these features, we add up the score. And if it's more than 6, the patient is high risk. So we generally do an EP study for intermediate and high risk. For low risk, we do not. Unless the patient has, other features, suppose they have non-sustained VT and they give a history of palpitation and, pre-syncope and all that, we generally do that. But all patients who in this hospital don't get EP study.
Dr. Deepak is asking us, would you similarly do an EP study prior prior to Epstein surgeries to look for a pathway?
That's a difficult question to answer. I think Dr. Shah had the same question. We have to be absolutely sure there's no pathway in these patients. We're absolutely sure they can go for surgery. But our bias always is to do EP studies, because even if we fail, we can always tell the surgeon where to cryomap and cryoablate, because the surgeon can use a freezing probe in the operating room. So our bias always, if there's any suspicion of a pathway or flutter, many of them actually have atrial flutter. We'll always attempt, we have low threshold for ablation in these patients in EP studies.
So even in the tetralogies, when you do the EP study, so if they're inducible, so then what do you do? Like you again go for cryoablation during the surgery, or what is the approach?
Actually, in this institution, it's slightly different. It's a little controversial. If the patient never had symptomatic VT before, and just we induced VT, then we'll try to ablate with the catheter here. We'll try to ablate, and then we'll also tell the surgeon to cryoablate on table. And as you know, the commonest response is between VSD patch and the pulmonary valve. So routinely they'll do an ablation there, or any of the other responses. And then we do a post-op EP study. And as you know, we do 5 extras here, not 3. 2 drive cycle lengths, 400 and 600, and 5 extras. And if the VT is non-inducible, then the patient goes home without a defibrillator. And we have a number of patients on follow-up. Actually, our manuscript is under review somewhere. You might be the reviewer, Raja, I don't know. But but it's under review. So we have a number of patients like that. But if the patient has sustained VT, and has collapsed earlier, whatever the EP study will give them a defibrillator, because we're not confident about the ablation. So only in the lower risk patients, we'll send them home without a defibrillator.
There's another question, John. So Suchit wants to ask about, what are the technical difficulties in doing a flutter ablation after surgery for Epstein's? Flutter ablation. Yeah, okay.
I guess you're talking about a bioprosthetic valve in the way. So we've done a few ablations, Epstein and other patients. I'm sure many of you have also done it with a bioprosthetic valve, and sometimes it's hard to ablate the tricuspid end. I don't know if that's, and if patient already has a previous maze surgery, or so there will be a lot of scar, and the reentrant circuits may not, it's just a general rule, may not make a lot of sense with multiple areas of scar and partial block and total block produced by these freezing probes. So other than that, I don't know.
I think if we don't have any further questions, we can thank Krishna for the wonderful talk and Dr. Vanitha for having made all this possible for all of us. And Raja, over to you.
Yeah, I think especially doing it as a case-based, showing us a lot of good cases and very nice images. It was very interesting. So thanks again.
Thank you all for a wonderful session. Thank you, Dr. KK, for sparing time. And thank you, Dr. Raja and Dr. John, for really saying yes to this session. I really enjoyed it. Though I don't do so much of complex congenital cases, but I really had a good time here. So more to this. I think KK has promised that he will show us more cases on congenital heart disease with VT, right? KK, do we have your word? We'll have you again very soon.
Yeah, sure. Yeah. Okay, sure.
Right. Thank you so much. I'm just signing off. All the best, everybody.
Thanks very much. Thanks for the honor for presenting. Thank you. Bye.
Keep safe.